Hello, it's Dr. Pearlz Clinical Rounds, here with another case. Let's get right into it. 25-year-old male presents to the clinic with a laceration to the right lateral thigh that occurred 5 hours ago. Patient was swimming in the ocean when he cut his leg against the edge of a sharp rock. Patient's Tdap is up to date. Patient has kept the wound wrapped with gauze and the bleeding has since stopped. Patient denies loss of sensation, numbness, tingling, or weakness of the right lower extremity. Vital signs are normal, and the right lateral thigh has an 8 by 0.5 by 0.5 centimeter linear laceration that is down to the dermis. There is no evidence of infection, devitalized tissue, or foreign body. Sensation is intact around the wound, and patient has full range of motion and strength of his right lower extremity. Popliteal pulse is 2+. If you need a refresher on wound preparation, please watch my previous video on wound preparation. Local anesthesia is administered and the wound is thoroughly irrigated with sterile saline. After confirmation of anesthesia, non-absorbable 4-0 nylon sutures are selected for the laceration repair. Given the size of the wound and for the sake of time, continuous or running sutures will be placed. To perform continuous or running suture, first, grasp the needle with forceps and with the needle driver. Load the needle driver 2/3 from the needle tip. The initial process is the same as performing a simple interrupted suture. Begin at one end of the wound and use forceps to gently evert the skin and insert the needle 3 to 5 millimeters from the wound edge at a 90-degree angle. Entering perpendicularly with the needle allows for better eversion of wound edges, which contributes to better cosmesis or thinner scar formation. Supinate your wrist and allow the curvature of the needle to do the work for you. You can perform this in one bite if the wound margins are not wide. Exit from the other side of the wound margin at approximately the same distance from the edge. Leave 1 to 2 inches of a short tail and perform a surgeon's knot. The next subsequent throws will be performed with 1 loop. Continue until you have 4 to 5 throws. Trim the short end of the tail so the length is approximately 3 to 5 millimeters. Next, you can move 3 to 5 millimeters from the initial suture or cross the long end of the suture across the margin to identify the next location. Load the needle and drive the needle through the tissue at approximately the same distance from the wound margins as the first suture, or about 3 to 5 millimeters. Make sure the needle traverses the wound margins perpendicularly rather than at an angle. This allows for better opposition of the wound edges. Note that the sutures on the surface will cross over diagonally, but the suture within the wound will be held together in a straight perpendicular line. Pull the suture gently and approximate the wound edges. Avoid pulling too tightly, as this may cause tissue strangulation and hypoxia, which can occur more often with continuous sutures. Try to grasp the needle 2/3 from the needle tip upon exiting the wound, as this will help minimize handling of the needle. You can then rotate the needle driver to reposition the needle for the next bite. Continue until you get to the end of the wound. The advantage of continuous or running suture is time. If the wound is actively bleeding or you are constrained for time, this technique can be very useful when speed is important. However, this technique may cause worsened scarring and should be avoided in areas where cosmesis is a concern. Disadvantages of this technique is the increased risk of wound dehiscence, increased risk of greater scarring and infection compared to simple interrupted sutures. For the final suture, insert the needle the same way as before. Do not pull the suture all the way and instead leave a loop. Perform a surgeon's knot by treating the loop as the short tail end of a suture, as with simple interrupted sutures. Perform 4 to 5 throws and cut the loop and long end of the suture to leave a 3 to 5 millimeter tail. After completion of the repair, wound was dressed with bacitracin, non-adherent gauze, and tape. Patient has saltwater exposure and is prophylactically treated with cephalexin with the addition of doxycycline for coverage of Vibrio species. Wound care instructions were provided and patient was advised to return in 10 to 14 days for suture removal. That's it for today. If you enjoyed the video, please hit the like and subscribe button. If you would like to see other similar content, please leave suggestions in the comment section. Thank you for watching, and let's move on to the next case.